This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Danish-Austrian IIH Consortium, or -IIH, recently published in the European Journal of Neurology, 2026. The paper is titled Surgical Interventions in Idiopathic Intracranial Hypertension, a comprehensive multi-center study of outcome and the role of treatment indication.
This is a timely topic, Ilara. We see these cases in the clinic all the time. The classic demographic of young, often obese, female patients with debilitating headaches and the looming threat of permanent vision loss. While we've traditionally managed idiopathic intracranial hypertension, or IIH, medically with weight loss and acetazolamide, the question of when to escalate to surgery is always a high-stakes decision.
Exactly. And what's interesting about this study is the scale and the specific focus on why we are operating. This was a retrospective multi-center study involving 3 major centers, Vienna, Odense, and Copenhagen. They screened a massive pool of 1,310 persons with IIH. They used the term PWIIH in the paper, who fulfilled the revised Friedman criteria.
1,310 patients? That's an impressive denominator. But out of those 1,310, how many actually ended up in the OR?
That's one of the first key takeaways. Only 3.6% required surgery overall. The researchers narrowed their focus to 36 patients who underwent surgery and had at least 6 months of follow-up.
3.6%. That really underscores that surgery remains the exception, not the rule, in IIH management. It's reserved for the fulminant or treatment refractory cases. Let's look at the patient profile of those 36. Did they match the typical IIH phenotype?
Perfectly. They were 100% female, with a mean age of 32.5 years. The median BMI was 37.0, and the median CSF opening pressure was 41 centimeters H2O. These were patients with significant pressure and significant symptoms.
A median opening pressure of 41 is certainly high. Now, let's talk about the surgical tools they evaluated. What interventions were these patients receiving?
The cohort was split between 2 primary modalities. 75%, or 27 patients, underwent CSF diversion, meaning shunts. The remaining 25%, 9 patients, underwent optic nerve sheath fenestration, or ONSF.
This is where it gets interesting for our residents and fellows. Choosing between a shunt and ONSF is a frequent point of debate. A shunt treats the global intracranial pressure, while ONSF is a more localized decompression meant to protect the optic nerve. What was the driving factor behind the decision to operate in this study?
The authors categorized the indications into 2 main groups. The vast majority, 83.3%, were operated on for acute visual deterioration. This is what we call the save site group. However, 16.7% were operated on for refractory headache alone.
Ah, the refractory headache indication. That's often a point of contention between neurosurgeons and our neurology colleagues. We know that shunting can sometimes alleviate IIH-related headaches, but the long-term success rate for headache alone is notoriously unpredictable. Did the IIH data shed some light on the outcomes for these different indications?
It did, and the results were quite stark. Let's start with the overall success rates at the 6-month follow-up. Across the whole surgical group, visual function improved in 41.7% of patients. Papilledema resolution, which is a major clinical goal, was achieved in 89.7% of cases.
Nearly 90% resolution of papilledema is excellent. It shows that both CSF diversion and ONSF are highly effective at decompressing the optic disc. But what about the headaches?
That's where the numbers drop. Overall headache improvement, defined as a 50% or greater reduction, was only seen in 30.6% of patients. But the real eureka moment in the paper comes when you look at the outcomes based on the indication.
Walk us through that.
If the indication for surgery was acute visual deterioration, the outcomes were generally favorable for vision. But if the patient was operated on for refractory headache alone, 2 things happened. First, there was no visual improvement, which makes sense as their vision might not have been the primary complaint, but it's important to note no collateral visual benefit was gained. Second, and more importantly, the odds of their headache actually improving were significantly lower. The odds ratio for headache improvement in the headache alone group was only 0.11.
0.11? That's a powerful statistic. It suggests that if the primary reason you are putting a patient on the table to cure their headache, you are statistically very unlikely to achieve that 50% improvement. The paper essentially argues that refractory headache alone appears to be an insufficient indication for surgical intervention.
Exactly. The authors suggest that in these cases, the headache might be driven by factors other than just pure intracranial pressure, perhaps chronic migraine transformation or medication overhead headache, which are common in this population.
It's a classic neurosurgical lesson. Treat the anatomy and the objective pathology, in this case, the pressure and the threatened vision, but be very cautious about operating to treat a subjective symptom like pain when the underlying pathophysiology might be multifactorial. Did they see any difference between the shunts and the ONSF?
They actually didn't find any significant differences in outcomes between CSF diversion and ONSF. Both were effective for visual preservation and papilledema resolution. This suggests that the choice between the two can remain tailored to the surgeon's expertise and the patient's specific presentation, provided the goal is visual protection.
That's a reassuring finding for those who prefer ONSF as a lower risk profile regarding systemic complications compared to shunting. However, we have to talk about the severe adverse events. Surgery in IIH is never a free lunch. What did the paper report on complications?
The study tracked severe adverse events, and as we know with shunts, they are not uncommon. While the paper emphasizes the efficacy and visual threat, they noted that the focus must remain on carefully managing treatment side effects and risks. While they didn't list every individual complication in the summary, the message was clear. Because the surgical rate is so low, that 3.6% we mentioned, we should only be doing this when the risk of blindness outweighs the surgical risk.
Let's dive deeper into the visual improvement versus papilledema resolution discrepancy. They reported nearly 90% papilledema resolution, but only about 42% visual function improvement. How does the paper explain that?
The authors point out that while surgery is great at relieving the physical swelling of the optic disc, the papilledema, the actual visual function, like visual field defects or acuity, depends on how much damage was already done to the nerve fibers before the surgeon stepped in. If there's significant axonal loss from chronic or fulminant pressure, the disc might look better after a shunt, but the vision won't necessarily return to baseline.
Which reinforces the need for timely intervention in the acute visual deterioration group. We can't wait until the nerve is pale and atrophic.
Precisely. The study uses the term fulminant IIH to describe those who need that rapid intervention. For our residents listening, the takeaway here is that if a patient is rapidly losing vision despite medical therapy, that's your green light for surgery. But if they have a stable visual field and are just miserable with headaches, you need to think twice or even 3 times before recommending a shunt.
It's a bit of a paradigm shift for some. For years, we've had patients practically begging for shunts to stop the pounding in their heads. This paper provides us with some hard data to say the odds are not in your favor for headache relief, and we might be exposing you to the risks of a shunt for very little gain.
It also highlights the importance of the multidisciplinary team. The IIH consortium itself is a testament to this, involving neurologists, ophthalmologists, and neurosurgeons. The paper notes that long-term outcomes in these patients are often driven by those chronic headaches, but surgery isn't the silver bullet for that specific problem.
So if we're summarizing the clinical pearls for the boards or for the clinic, 1. Surgery is rare, needed in less than 4% of IIH cases. 2. Both shunts and ONSF are excellent for resolving papilledema. 3. Vision improves in about half of the surgical cases, likely limited by pre-existing nerve damage. And 4, the big one, refractory headache alone is a poor indication for surgery.
Correct. And I think it's worth mentioning the study's limitations. It was retrospective, and the sample size of 36, while significant for a surgical IIH study, is still relatively small. However, being a multi-center study across 2 countries adds a lot of weight to the findings.
It certainly does. It's also important to note that they use the revised Friedman criteria, which is the gold standard for ensuring we are actually talking about IIH and not secondary causes of intracranial hypertension.
The authors conclude that CSF diversion and ONSF are effective in IIH with acute visual threat, but we must be much more selective when headache is the primary complaint.
This is a great example of how less is more in neurosurgery. Just because we can divert CSF doesn't mean we should, especially when the goal is pain management in a complex patient population.
Absolutely. It's about the right treatment for the right indication.
Well, Ilara, I think that covers the main thrust of this IIH study. It's a concise, powerful reminder of our surgical priorities in IIH.
I agree. It definitely gives us more confidence in our decision-making process during those difficult multidisciplinary rounds.
Thank you, Dr. Ilara. And to our listeners, thank you for joining us on the Neurosurgery Hub podcast. Keep an eye on those visual fields, and we'll see you next time.
See you next time.